それでは次のスピーカーに移ります。ポストトラウマティックメンタルヘルス The View from Australia、ダリル・ウェイド先生、よろしくお願いいたします。先生についてご紹介申し上げます。先生はメルボルン大学精神医学部准教授、教育トレーニング部ディレクターをされておられます。さまざまな精神保健機関で勤められました後、オーストラリアの心的外傷後精神保健センターに2008年に関わられ始めまして、そうした中で治療やアクセスの向上をですねに取り組まれて、特にトラウマ災害に影響を受けた方々に対する対応についてさまざまな努力を行ってこられておられます。また若年層の精神保健問題に関して幅広く出版物を持っておられます。先生、それではよろしくお願いいたします。
Thank you very much, Dr. Noda. Firstly, I'm very grateful for the opportunity for speaking at the symposium. I'd like to thank the organisers of the symposium and also to thank the people, the policymakers and researchers and practitioners who I've met with over the last few days, who have given me their time, and I've learned a great deal from meeting those people and from those discussions. What I'd like to do is just spend a little bit of time talking about some of the work that we do at the Australian Centre for Post-Traumatic Mental Health, and with a particular focus on disaster mental health. So this is locating Australia in the world. The good news is that Melbourne, where the arrow is, and Tokyo are in the same time zone, which is very much going to help with collaboration. But the thing that I think of when I look at this map of Australia in the world is just thinking of two populations who are at high risk of developing post-traumatic mental health problems. Firstly, they're the members of the Australian Defence Force who we send overseas on deployments to war zones. Many of you will know that we've had thousands of young men and women from Australia serving in the Middle East for over a decade now, and they're certainly a high-risk population. The other population, the other group of people that I think of are people fleeing persecution and war in other countries and coming to Australia as refugees. And they also are a group of people who have very high rates of post-traumatic mental health problems. But closer to home, this is the area where the Australian Centre for Post-Traumatic Mental Health is located. It's in a very strong Catholic area of Melbourne, and this is St Patrick's Cathedral, which is just up the road. This is the office building. Opposite the office is a very nice garden, so I perhaps should have taken a photo of that instead of the building. And you would have also seen these people as well. They're not the security guards. The fellow on the left is Professor David Forbes. He's my director, and we also were very pleased to host Dr. Tashimori and Dr. Kawano, and also Dr. Nishi as well at the Australian Centre for Post-Traumatic Mental Health. This is how most people find out about our centre. This is how most people find out about useful information about post-traumatic mental health problems. And in August this year, we have a leading trauma expert coming to run a masterclass in Melbourne, sponsored by our centre, and that's Professor Edna Thoa. So I'd encourage you to have a look at our website for if you're interested in the issue of post-traumatic mental health. Our mission is to improve the well-being and quality of life of individuals and communities affected by trauma, and we do this through three streams of work. we do exciting research, we provide policy advice and develop services for government as well as non-government organisations, and we also provide education and training services, which I'm the head of. In terms of our research, one of the large research studies that we've been running recently is looking at mental health outcomes of individuals affected by severe acute physical injury, traumatic injury, and admitted to level 1 trauma centres. And there's two, this is a graph showing the prevalence of mental health problems 12 months after the physical injury. And if you look at the column on the far right, it shows that at 12 months, 30% of people had a mental health disorder, and about 2/3 of those had an onset after the traumatic event, and about 1/3 had the onset prior to the physical injury. The other thing I'd like to just point out is that although post-traumatic stress disorder is often seen as the signature disorder following trauma, in actual fact it may not be the most prevalent problem. And in this population, certainly there were other disorders that were more common than PTSD, including major depression and generalised anxiety disorder. This report made the point that when we look at the level of disability that patients are experiencing 12 months after an acute physical injury, what contributes most to that level of disability, what prevents the community members from doing the sorts of day-to-day things that they want to do, is not the physical injury. It's actually the mental health problems that are making the major contribution to the level of disability experienced. Much of our work, including our policy and service development work, is informed by the Australian guidelines for treatment of PTSD that we've developed in collaboration with a range of experts. We are about to launch the revised guidelines in August this year, and that will include recommendations about best practice for children and adolescents as well as adults. And this is really a vehicle for informing the community as well as practitioners and policymakers about what the experts say and what the evidence says about what is the best way to treat and support affected people. And where we have the strongest evidence is in psychological therapy. So for those people who have developed a mental health disorder like PTSD, then the strongest evidence is for the delivery of psychological interventions where possible in the first instance. And that's certainly what we're trying to train practitioners in delivering. So the real challenge is not so much about lacking evidence for what's effective. The real challenge is about enabling patients, people who are suffering from these problems, to get the access to those effective treatments. So I would just like to preface my what I wanted to say about disaster mental health by looking at these response trajectories. Now, the green line perhaps shouldn't be so straight. It probably should dip somewhat early on. But the point here is that most people will only show transient distress over the first days or weeks, and then will return to their normal functioning, or will show a recovery trajectory. In other words, they may show substantial loss of functioning in the months after a traumatic event like a disaster, but we can expect that they will recover with minimal intervention, possibly in a disaster situation, as the material environment improves. and that only a minority of people will develop a mental health disorder. And this certainly has implications for how we go about planning a disaster mental health response. We rely on a fairly simple multi-level framework to guide mental health response in Australia. And it looks something like this. At level 1, in the days and weeks following an event, we think that the best way to support people is to provide them with information, advice and practical support, and not to deliver structured psychological therapies in that initial period, because we can expect that a lot of people will, their distress will start to improve in those days and weeks. For people who have more persisting, mild or subclinical problems in the weeks and months following an event, then we also think that there would be an opportunity to provide them with to teach them simple psychological strategies to cope with their difficulties. And then finally, we want to reserve the specialist mental health services for those who are most in need, those who have formal and more severe mental health problems. This just illustrates some of the affected areas. In 2009, we had significant bushfires in Victoria, Australia, which devastated a number of communities. So we, in partnership with Beyond Blue and government and other organisations, were involved in providing support to those communities and developing information and programs to help those communities. And one of the programs that we developed was with Beyond Blue and with funding from the Department of Health was what we called the Community Support Training Program. And in essence, this was an opportunity for community members to come together in their own community to share their experiences, but also to learn about typical mental health responses following trauma and where to go for assistance if somebody, if they were concerned about somebody or indeed concerned about themselves. And the evaluation of that program seemed to indicate that it was well received by those community members and also improved the skills and the knowledge and the competencies of the community members who attended. At the second level, we have been using the program that Dr. Nishi mentioned, which is Skills for Psychological Recovery. So this is an approach which encourages practitioners to deliver brief, simple, low-intensity psychological interventions in a flexible way to people who are having persistent difficulties following trauma or disaster. We had large-scale floods in Queensland in 2010-11, and the main feature of these floods was the economic damage that it caused across the state. So we had very few deaths, but it certainly paralysed Queensland for quite some time. So as part of the Queensland mental health disaster response, we rolled out a large-scale training and support program for people in Skills for Psychological Recovery. On the left-hand side, you can see the extent of flooding in Queensland. Queensland is about 5 times the size of Japan in landmass, and you can see that the flooding went right across the state. And on the right, you can see where we ran training sessions, and we ended up training about 900 practitioners So general practitioners, psychologists, counsellors, community workers in this program. We don't have very good data about how effective it was, but what we do have suggests that there was some improvements. So if you look at the bottom of the graph here, you can see that the skills were problem solving, promoting positive activities, managing distressing psychological reactions, rebuilding social connections, and promoting helpful thinking. And you can see that the practitioner's confidence to deliver SBR interventions, to teach community members these interventions, improved over time. We followed them up over 9 months, and there was a significant shift from pre to post training, and that seemed to be maintained over the 9-month period. But most importantly, did these practitioners actually use the program? Did they actually teach the skills to community members? So this looks at 3 consecutive 3-month periods. So in the first 3 months, 36% said that they didn't, 38% said that they didn't, and 44% said that they didn't use SBR. But across those periods, roughly half to 2/3 of practitioners said that they actually did use the program, which we thought was quite encouraging. We adapted the SBR program to use following the Victorian bushfires, and specifically to help parents who were experiencing difficulties themselves, or who had a family member who was experiencing difficulties. And what we have from this program is some outcome data from the parents who attended the program. And there's no comparison group. It's not a controlled trial. It's just a naturalistic design showing that the severity of depression, anxiety and stress did seem to improve with treatment and continue to improve. And also that the parents' own satisfaction in their parenting skills, and also the confidence in their parenting skills did improve from during the 6-week period from pre-treatment to post-treatment, and also was maintained at follow-up. And lastly, if I can just mention that as our experience in the Victorian and Queensland disaster response, with that experience, we realised that not everybody could attend face-to-face training, and in particular, general practitioners found it very difficult to come to that training. The general practitioners are family physicians who are a central component of our primary and mental health services. So we've recently completed an online training program for general practitioners. This was funded by the Department of Health and Ageing, and we developed this in collaboration with the Royal College of General Practitioners in Australia. So we're very much hoping that in the months and years to come, that the 21,000 GPs who are working in Australia will access this program and learn more about the 3 levels of care that we advocate. So in terms of the future, for us it's about building capacity in all aspects of the workforce, for specialist mental health practitioners to align their practice with evidence-based treatment, for primary care to have greater capacity to manage post-traumatic mental health cases, and also to build community capacity for the community to be able to, community members to be able to support each other and to feel confident that they can do that. very much.